All right, you guys are ready? We'll go ahead and get started. Mostly because this is a long talk, and we're just not going to get through all of it now. It's just not going to happen. So here's what's going to happen, though. This is the Wimpy version. The Wimpy version, I kid you not, is 188 slides. So this is the Wimpy version. So we're going to fly through this. If you have a seizure disorder, you just double down on your AEDs right now, or look away. Just listen, look away. I'm going to send out both this and an unabridged version of this talk to you guys. The unabridged version is about 300 slides. It's not worth going through in an hour. It's not worth going through in 3 hours. It's there because I think it's a reasonable fly through the literature of things that are actually important for you. So we're going to emphasize some things, de-emphasize some things during this talk. Somehow at the end of the hour, we're just going to be done, and we're just going to have done some sepsis. All right, you guys ready? All right, let's do this. Okay, so this is one of those things, we all kind of know it. We think we know it. We have a feel for it. It's common. 750,000 people with septic shock, not just sepsis, septic shock in the U.S. annually. Hospital mortality has actually decreased significantly in the last 10 years. So when you look at studies in the early 2010s time period, compliance with the Surviving Sepsis Campaign bundle over a 7.5-year time period was associated with a 25% relative reduction in mortality. We'll get back to that, don't worry. I'm not advocating for it, I'm just saying it's a thing, and this is where we're starting. And then application of the bundle was felt to directly result in improvements in mortality over the last decade. All debatable points, but that's kind of where we are. So we're going to talk about a lot of things. Some we're going to talk about a little bit more than others. Here's the thing. Here's my take on this, just so you guys know. Your bread and butter is sepsis. I don't care what kind of critical care you do. Your bread and butter is sepsis. You have got to be better at sepsis than anybody else out there, okay? Because that's your thing. That is your territory. And you need to understand this inside and out. And so there's a lot of components to this, and I'm going to tell you there's more, at least in my opinion, there's more out there about septic shock that we don't know by far than what we know, okay? So what I'm going to try and do is wade into some of the controversies that are out there in each of these areas, but at a minimum, I want you to understand the concepts behind all these things. This is really important. The concepts themselves are key. So we're going to define septic shock. So previously we talked about, well, we have to have at least 2 SIRS criteria for a systemic inflammatory response, and we have to believe that that's due to an infection. You don't even have to prove it. You don't have to positive cultures. You just have to believe. You gotta, I really believe this is an infection. It's less than satisfactory though, right? If you have somebody with, say, asthma exacerbation, they're tachycardic and they're tachypnic, and if you believe there's a viral infection triggering this, then guess what? They're septic. Well, of course not. Of course you're not. But that's a problem with the definition. It was designed probably more for research definition and probably more for sensitivity rather than specificity. The problem is we may have been missing some people who needed more care, and we may have been over-identifying people who don't need that. So not perfect. So they went back and they said, okay, let's look at this definition. How well does it perform? Really interesting thing. If you look at an unadjusted annual mortality of people who had SIRS-positive sepsis versus SIRS-negative sepsis, so they all actually had an infection syndrome that was proven. Some people met SIRS criteria, some people didn't meet SIRS criteria. But they all ended up with bacteremia or absolute infection with evidence of organ failure. If you look at unadjusted annual mortality, it turns out it's coming down for both. And there's a separation between those who qualified as SIRS and those who don't. So you look at it on the surface and say, maybe SIRS is actually pretty good because we're identifying sicker people who clearly do worse. But if you actually adjust all those people for organ failure, for all the other things going on in their illness and disease severity and everything else, what you actually end up with is whether or not you're SIRS positive or SIRS negative didn't actually help to distinguish how you were going to do. So it probably wasn't that helpful. This was the unadjusted mortality number SIRS criteria met going up. Mortality goes up. That's kind of what we expected. But with the adjusted odds of death, it sort of looks like it's going up, but if you look how wide the confidence intervals are. So it turns out the SIRS definition probably not perfect. So the sepsis 3 guys came along, third international consensus definitions for sepsis and septic shock. They said, look, we need a better definition. We need something that identifies not just people who are likely to be infected, but people who are likely to die from infection. Because that's really the group we want to target. That's the group we want to do something about. So we define sepsis as those with a SOFA score of 2 or more, and that group defines a 10% in-hospital mortality. Septic shock is sepsis with adequate volume resuscitation, however you want to define that. There were some recommendations in sepsis 3 about a volume cutoff and other things. And a vasopressor requirement necessary to keep a MAP greater than 65 or a lactate greater than or equal to 2. That group defined a 40% in-hospital mortality. So they said, okay, now if you want to identify out-of-hospital at-risk patients, you can use a QSOFA, and there's 3 components to that. As we'll see in just a second, altered mental status, respiratory rate, and SVP. So the components of a SOFA score, you're basically using respiration, coagulation, liver, cardiovascular, CNS, renal, and you're grading in 1 through 4. Okay. SOFA score of greater than or equal to 2. Doesn't take much. Doesn't take much. But so QSOFA though, finding 2 out of these 3. Again, a lot of people on the surface you would expect would qualify as having 2 or 3. So where did sepsis 3 come from? It came from Pitt, largely. Pitt and the University of Washington guys, but most of this was done out of Pitt. 12 hospitals in the system, and what they did was they said, okay, we're going to take all of this data, which things identify people who are going to die, which things identify those who won't. We're going to separate these 2 things, and then we're going to do a validation cohort. They did a validation cohort at 165 hospitals throughout the U.S., all major facilities. And they said the predictive validity for in-hospital mortality using SOFA, QSOFA, and SIRS was 0.74 for the SOFA score, and the QSOFA and the SIRS were almost identical. So SOFA seemed to be better at predicting in-hospital mortality. However, the predictive validity for mortality in general for a non-ICU patient, person on the floor, patient coming into the hospital, QSOFA performed better than either the SOFA or SIRS. So this is why we use QSOFA to define out of ICU, kind of as a screen almost. And then if you really believe this person is septic, we look at the SOFA score to get a sense of in-hospital mortality. Who used to go to an ICU? Who do we need to pay more attention to? So I like to keep things simple. Okay, I was educated at a state medical school in the South. We are simple people. Sepsis really comes down to 3 big things: vasodilation, endothelial leak, DIC. Everything you're managing is really going down these 3 things. And there's a lot to that. But let's talk a little bit about oxygen delivery. I love oxygen delivery, love talking about it. We talked about it a little bit this morning, so sorry. In the second round through this conversation. I spent all morning practicing my septic shock talk this morning as we were going around. So I was very erudite on multiple things as we went around from bed to bed today. But oxygen delivery is a function. Cardiac output, hemoglobin, SaO2. It's also a function of 1.34 or 1.39, depends on who you read. Which is weird because that actually just adjusts for units. So that number should be the same. But it turns out in different papers it's actually different numbers. It's 1.34 in some, 1.39 in others. And then there's this PaO2 piece out there that you multiply by 0.0031, okay? If I'm concerned about how we're doing in shock land, I don't care about your ABG from a PaO2 standpoint. Don't care. I'm very interested in your acid-base status. There may be other reasons I'm interested in your PaO2, but resuscitation is not one of them. I don't feel any better about a resuscitation where my PaO2 is 85 versus 59. I don't care. I care about my SaO2, and at some point those 2 tend to track together, of course. But the SaO2 is what I care about. Okay? Locomotive, number of trains the car is pulling. If each train has 100 seats, how many are filled with people? That's it. Okay? Keep it simple. It's not hard. So, these are all the pieces. We talked about that. So, oxygen delivery, takeaways. So, cardiac output's important. Hemoglobin is important. Saturation of hemoglobin is important. PaO2, not a big player. Now, if you're talking about pregnant patients, okay, and PaO2 gradient is how you're getting oxygen across the placenta, then it's a big player. Okay, then it's a big player because it's a big player for baby, but not so much for mom per se. So how do we know when we have the right combination? Really, really important, right? This is not such an existential point as I'm going to make it sound. There are very few places in the world where there is as big a power imbalance between two humans as there is between ICU provider and patient. Prisoner, detainer, right? Clergy, somebody following. These are big power imbalances. I'm not saying they're all identical, but they are big, big power imbalances. You are making huge decisions, throwing around a lot of resources to a person who doesn't actually get a focus. And the notion that there's actually going to be true informed consent on any of these topics with anybody you're talking to, good luck. Good luck, right? So you are going to do very aggressive things to people, okay, in the name of trying to make them better. So if you're going to go down and start messing around with cardiac output and hemoglobin and saturation, you better be very clear on what your goals are. And you need to be very clear on, in your head, how are you going to decide whether this given patient has the right combination of these things to make a decision about whether you need to muck with any of these things. Just because the person's EF is 30% doesn't mean you need a balloon pump today. Maybe you do, maybe you don't. It depends. So you have to kind of weigh all these things together and be clear where you're driving. So endpoints of resuscitation. So defining shock. You can either have inadequate oxygen delivery, you can have increased oxygen uptake requirement relative to whatever delivery you have, which are kind of the same thing, but not quite. And then third, maybe you can take up plenty of oxygen, but you can't use it, right? So I was in Vegas a couple months ago with my dad, and we live at all these buffets. I know all the good buffets. The Aria has a great buffet. The Aria is fantastic. It's got a great buffet. Highly recommended. Okay? I don't care how much food you put in front of me at the Aria. If my mouth is taped shut, I know all of you wish that, but if my mouth is taped shut in front of this buffet, you can put as much food in front of me as you want, and there's plenty of food there. I may still starve to death unless I can eat it. Cells may be the same way. That's a big problem in septic shock. You may find that you're resuscitating the snot out of somebody, but maybe they can't use it. And we're going to hit that topic in a minute. But key players, oxygen delivery, oxygen uptake, and the extraction ratio. The extraction ratio is how much are you taking up relative to what you're getting, okay? And my assumption is if you're thirsty, you're going to take up more, right? If I put 10 bottles of Gatorade in front of you and you're really thirsty and you drink 8, that tells me you were thirsty. If you're not thirsty at all and I put 10 bottles of Gatorade in front of you, nothing, right? If you don't drink anything, then I say, oh, they must not have been thirsty, right? May or may not be the best assumption, but it seems to make some sense. So when we look at oxygen consumption on the vertical axis versus oxygen delivery, we tend to draw it like it looks like this. It doesn't really look like this. It's actually this kind of looping long graph that comes out like this. It's not quite flat. But there's two parts we identify. One is a supply-dependent part, and another is a supply-independent part. On the supply-independent part, past this critical oxygen delivery point, no matter what I do to your oxygen delivery, you don't uptake any more oxygen. It is supply independent at this point. Your uptake is now supply independent, okay? I get the idea that if that supply actually went away immediately, you would all of a sudden be supply dependent. I get that. But the argument for that would be if all of a sudden this goes away, it's because you're now on the supply dependent part. And the supply dependent part means that every up or down you go on the oxygen delivery part of the graph, that will necessarily link to an up or down on the oxygen uptake. You cool with that? You down with that? All right. You should also appreciate that the maximum extraction ratio, VO2, DO2, is defined by the slope of this graph. Right? The steeper the slope, the higher the extraction ratio. The lower the slope, the lower the extraction ratio. Got that? Okay. All right, now, so how do we make these magical changes? So we change the redox state down the mitochondria, okay? We start messing around with cytochrome, electrons go down, help me out, what? Yes, thank you. So oxidation favors moving to the right, reduction favors moving left. You don't need to memorize that. The point is, if you can demonstrate in your patient an increase or a decrease in the extraction ratio, you've learned something very important about your patient, which is that their cells are largely still intact and their mitochondria are still functioning. Because when the mitochondria fail, you lose your ability to move left and right on this graph, and we'll talk about that in a second. So way out to the right, your extraction ratio is very low. Remember, extraction ratio is VO2 over DO2. So if my VO2 is flat, but my DO2 is getting bigger and bigger and bigger, my extraction ratio is getting very low out to the right out here. Over to the left, my maximal extraction ratio happens in the supply-dependent portion. Okay? All right, now, compensated versus uncompensated shock. Uncompensated shock is really easy to figure out. That's not hard. You don't have to be a rock star to figure out that the person in front of you with no blood pressure is probably in shock. The person in front of you whose SATs are 45 and their lips are blue is probably in shock. The problem is, so much of what we're dealing with in critical care is compensated shock. And that's really a challenge. How do I look under the hood and figure out stuff isn't actually going well? Because I'll tell you, if you don't figure that out, your person still dies. They may have a great blood pressure. If you're on norepi of 40, you may be critical care rock star today, but 3 days from now, you find he's got dead gut because you didn't actually adequately resuscitate him. Okay? And it's really, really important. So that's your job, is really to live in this land of compensated shock, which is a difficult thing both to identify and to figure out what to do about it. So the perfect endpoint of resuscitation would be cheap. It would have great sensitivity and specificity. You'd be able to use it in any environment, and that would be great. And it would work for multiple types of shock. It would tell you what to do. So it doesn't exist. There is no perfect endpoint of resuscitation. So your job as an intensivist, and part of what you get paid to do, is to say, okay, this is what's out there in terms of accepted endpoints of resuscitation. How do I put them together in my given patient in this situation and make it talk to me? Okay? And again, if it was as easy as it's always lactate or always stat or whatever, it'd be a short talk, man. We wouldn't need 188 slides for the Wimpy version of this talk. Absolutely not. We had like 4. So here's some options. Okay, we're going to play a little bit with a couple of these. We won't spend too much time with all of them, but there's some options. On the unabridged version of the talk that I'll send out to all of you guys, we go into a lot more detail about all these things and hit some of the literature for each of them. So lactate, one of my favorite moments as an attending ever happened about 3 years ago. I was in the NICU, and we were talking about endpoints of resuscitation. And I was trying to make the point that you're always making some lactate. Right? Just because you have some lactate doesn't necessarily mean you have inadequate oxygen delivery. And so I said, I looked around the room and I said, so raise your hand if your lactate's 0. And of course, nobody took the bait. Nobody raised their hand. And then I said, so that means each of you, some part of you is dead. And without missing a beat, the resident right in front of me, he just looks up and he goes, there's a little piece of me that dies every day. And I was just like, it's so sad. And I wasn't sure if he was serious or not. Do I get help for you? Is this a cry for help? Or do I just laugh and then regret the laugh later? I wasn't sure. So I laughed, and he's still alive. He's doing good. So who knows? So lactate is used a lot as an endpoint of resuscitation. And that's not an unreasonable thought, and we'll hit that in a little bit. But just understand, anything that causes pyruvate elevation will cause lactate elevation. Anything. So all the sympathomimetics, epinephrine, terbutaline, retidrin, all these things will cause an increase in pyruvate and therefore an increase in lactate. It is best to think of lactate as a marker of metabolic stress. One cause of your metabolic stress may be inadequate oxygen delivery. Okay? But don't think, so we have albuterol-induced lactic acidosis several times a year. We get an asthma person up from the ER, got a lot of albuterol, which is not unreasonable. I mean, they were asthma exacerbation, they got their albuterol, and there's some proportion of patients out there who will generate a lactate of 6 or 8, like me. So I did this as a fellow. I tried to convince my IRB to let me give a whole bunch of albuterol, like a whole bunch, to mild intermittent asthmatics to show that I could generate lactic acidosis, because I'd seen somebody arrest from this before when I was a resident. And they said, yeah, we don't think that's a good idea. So I double or triple concentrated an albuterol net, and we did this for an hour. I remember I was watching Ricky Lake, and I got really, really jittery, and I took my lactate up to 8 and cleared it within about an hour. It goes away and all that stuff. And, you know, so it's out there, okay? You can push your pyruvate around. But for one moment, I had more pyruvate than anybody else in my medical center, so I don't mean to brag. What we do know is that changes in lactate at baseline have prognostic value. Those who present in a shock state with elevated lactate do worse. Those who don't clear lactate the first 24 hours, we know this from trauma literature in particular, they don't do as well. Base deficit. What is a base deficit? Because people throw this around a lot. They throw it around a lot. So when you say somebody has a base deficit or base excess, what you're actually describing is a pH that's high or low. That's it. If you have a base deficit, you have a low pH. If you have a base excess, you have a high pH. That's literally all you are saying. Because what a base deficit is the number of millimoles that you have to add of bicarb to a liter of whole blood in order to make somebody's pH 7.4, assuming the PCO2 is 40. So I live in a land in the medical ICU where nobody's PCO2 is ever 40. So it's an adorable construct. But really all it's telling you is the pH is high or low. It's telling you how high or low. So is it helpful? I don't know. It depends, right? It's all about context. Do I use base deficit much in the medical ICU? No. If I have a fresh trauma person who comes in, so our gentleman is 16, I have a fresh trauma person who comes in this morning and somebody tells me his base deficit is 14, and there's nothing else on board, there's no alcohols, things like that, and he's breathing otherwise okay, I would assume something very bad is going on. Let's say I take somebody back to the OR and I'm going to do a hip on them, and they start out with a base deficit of 0. Okay? You grind away, there's bone chips and blood everywhere, and the next thing you know, the base deficit is 4. Well, that probably does mean you need more blood. Why? Because you probably bled, you have decreased oxygen delivery, you now have lactate elevation. That's probably not unreasonable to take that base deficit and say, I need to resuscitate somebody. If I take a COPD exacerbation upstairs in the ICU and I measure their base deficit right before I intubate them, it's going to be abnormal. Because the assumption is the PCO2 is 40, never mind the fact that PCO2 is actually 90. Right? The assumption is the PCO2 is 40. So I would look at that base deficit and say, you need volume and I need to resuscitate. No, I probably need to intubate you. Right? So is it helpful? It depends on the setting. It's neither good nor bad. And that's the theory we talked about. So mixed venous sats, central venous sats, we're just going to go through the concept real quick. I don't want to spend too much time on this because I know that you guys are all very well aware of it and ensconced. But going back to the Gatorade, right? I assume if you're alone on an island and I'm driving by in my fancy yacht, if you're sitting there on the island and you're thirsty and I give you a box of 10 bottles of Gatorade and you drink all that 10 bottles of Gatorade and you send the box back to me and it's now empty, you were thirsty. I give you another 10 bottles of Gatorade. This time you drink 5, you send the box back to me. Oh, you drink 5, you're still thirsty. I send you another box of 10 bottles of Gatorade. This time you're just pissed off. Okay, you want me to take you off the island, put you on the boat, take you back to Miami. Okay, but I'm not going to do that. I'm just sending you the Gatorade. You send the box of Gatorade completely untouched back to me in protest. So I say, Jordan's not thirsty anymore. That's what I read from this. I expect Jordan to drink 3 bottles of Gatorade or less from every 10 I send him. If he drinks more, he's thirsty, and his needs were not being met until I gave him that Gatorade. If he drinks less, then he must not be thirsty, right? So that's the idea between mixed venous saturation. What I'm looking at is oxygen delivery relative to relative to what's left over at the end of mixed venous sat. This is the oxygen in the blood right before you pick up new blood in the alveoli, okay? This is Keith Haring, by the way. I'm just going to give you some advice, and don't worry how I know this. If you are going to go on, say, a first or second date at the San Francisco Museum of Modern Art, and you are going to take your date to Keith Haring exhibit. Not all of the art that Keith Haring did was this kind of stuff. Keith Haring was very troubled, and if you're going to take somebody to that kind of exhibit, just make sure you understand in what ways Keith Haring was troubled. Very disturbing art out there. Miss Keith, but still. So mixed venous oxygen delivery is a function of cardiac output, hemoglobin, and mixed venous saturation, and the pVO2, the amount of O2 that's still dissolved in the blood. Arterial oxygen is what we talked about earlier. So if the saturation is 100% at the beginning, you are the greatest pulmonary doctor in the world, and the saturation of blood on the arterial side is 100%, then the ratio, this mixed venous oxygen to what you started with, MVO2 over DO2, becomes the equivalent of SVO2 over SaO2, right? Because this crosses out, this crosses out, this crosses out. These are both negligible. So it's SVO2 over SaO2. And if you assume that this is 100% the denominator, then your SVO2% reflects what's left over, okay? You follow me? So if you consume 30%, then this ratio should be 70%. If you consumed 70%, then this ratio should be 30%, because this is the leftover, right? Okay, so if my extraction ratio is this uptake, then my extraction ratio is, so if we say that MVO2 is equal to DO2 minus VO2, so the amount we started with minus the amount we uptake, we just rearrange this so VO2 is the same as what we started out with minus what we ended up with, okay? So if I plug this into the extraction ratio equation, then my extraction ratio is what we started with minus what we ended up with over what we started with, which is 1 minus this ratio. Okay, if your SATs were 100%, then this ratio becomes the SVO2. So my extraction ratio is 1 minus mixed venous sat. The other way to look at it is my mixed venous sat is 1 minus extraction ratio. If my mixed venous sat is 80%, then my extraction ratio must have been 20%, right? If my mixed venous sat is 20%, then my extraction ratio must have been 80%. It gives you some window into how thirsty the body is, in a gross sense, So going back to this redox stuff, right? So if my normal ratio is 15 to 30% in terms of my extraction ratio, then that means my mixed venous sat is going to be what? It's going to be 70 to 85%, right? If my maximal extraction ratio is 60 to 70%, that means down here, my mixed venous sat would be 30 to 40%, right? See? We did that without having math. I went to a liberal arts school, so this is big math for me. Okay, some of you guys were chemistry majors, did PChem and all this stuff. Not this guy. Kingdom, phylum, class, order, family, genus, species. That has served me well in my medical history, in my medical life. So, elegant concept. Mixed venous sat is low. That means your extraction ratio is high, which means you're under-resuscitated. You need to fix cardiac output and or hemoglobin and or SATs. Okay? If my extraction ratio is low and my mixed venous sat is higher than expected, then, oh, you must be resuscitated. It's an elegant concept. There's always a fly in the ointment, because if it were that easy, it would be a short talk. And you're like, yeah, it would be. But it's not. It's not. So what happens when your cells start to break down? What happens when the machinery in the cell starts not doing what it should be doing? What happens when your redox manipulation, state manipulation at the level of the mitochondria fails? What happens is you end up with some extraction ratio that represents a maximum extraction ratio across the entire oxygen delivery spectrum. You are now in a supply-dependent situation forever. And your mixed venous sat is going to be what? It's going to be high because your extraction ratio is low. So when somebody is resuscitating a septic shock patient, and I come in and I say, hey, what's going on? And I ask you about mixed venous sat, do I feel better about 90 or do I feel better about 40? I actually feel better about 40. because I know they're under-resuscitated and I know what I got to do now. At 85 or 90, really bad things are going on. Now, maybe it's appropriate, right? Cardiac cells, they hibernate when they don't see enough oxygen, right? They won't extract much oxygen in that setting. Maybe these are cells doing the right thing. Maybe these are cells that are pretty jacked up. I'm not sure. And I don't have a great way of knowing that, other than some gestalt looking at other stuff. It's really hard to know. But this may be part of the problem, why things like super physiologic oxygen delivery maybe is helpful in some people, because if this is your stay alive line all the way across here, that means in order to stay alive, I would have to have this oxygen delivery. Maybe. I would say it's probably also an argument why jacking up the oxygen delivery in most people doesn't really benefit you, because those who are more sick probably don't benefit from not only supernormal oxygen delivery, they may not benefit from normal oxygen delivery, frankly. Unfortunately, the bedside's all you got. You can't control the cells quite yet. Mixed venous stat, in order to measure it, we have to get it from the distal tip of a PA catheter. So, do we put in PA catheters everywhere with septic shock? There's like someone up front saying, yes. No, I'm kidding. I'm just, no. I actually, in probably the entire, outside of cardiology and the entire Department of Internal Medicine, am probably a bigger fan of mixed venous PA casts than anybody, except for maybe Jean Owen. She likes PA casts better than I do, but she likes it for evidence-based reasons, not me. So the question is, can I approximate that in any other way? And the answer is yes. If I measure blood from the distal tip of a triple lumen in the SVC, that correlates with the mixed venous sat out the end of the PA cath. Now, there's always someone in the room who's got to talk to me about the Bayesian circulation, shit like that, and somebody's got to tell me that oxygen extraction ratio from above is different from below. Absolutely, all those are true. They are not identical numbers, but they do trend in exactly the same direction, and that's all I care about. Okay, if I'm resuscitating somebody, I want to know my mixed venous sac is going to move in the same way that my SCVO2 will. So a low SVO2 or SCVO2 says you have inadequate oxygen delivery. Okay, you got to make sure you're satting well. You got to make sure you have adequate preload. Make sure you have adequate contractility. Make sure your hemoglobin is where you want to be. And again, this was a lot more helpful 15 years ago before we didn't have bedside ultrasound, because this was your window into cardiac function at bedside. This and the PA cath were what you had. Bedside ultrasound, Jordan can walk up, stick a probe on that thing in 4 minutes and tell me what the hemoglobin is, right? He'll tell me these things. I swear to you, he will tell me these things. He's tried to show me how to look at papilledema, and he will tell me the person's visual acuity. It's 20 over 40. I said, what? And he's like, and the problem is he knows I don't know enough about it to call him on it. I think he's making it up, but I'm not sure. The problem is a normal or elevated SCVO2 doesn't help you very much. In the context of something that improved, maybe it makes you feel a little bit better, but as an endpoint of resuscitation may not be helpful. And I think this probably came up in part during PROMISE process and ARISE. But so endpoints of resuscitation takeaway, lactate may be helpful in the right context. Low SCVO2 may be helpful in the right context. We didn't talk about changes in PCO2, but they could be helpful. But unfortunately, in spite of heroic efforts to alter systemic oxygen delivery, we don't seem to have moved the needle much in terms of resuscitation at that point. Yes? Yeah.
So, based on that last slide and your discussion thus far of SCVO2 and SCVO2,
yeah.
How do you address the generally perceived belief at the bedside that if your hematocrit is reasonably normal and your PaO2 is reasonably normal, that changes in SVO2 or SCVO2 are very proportional to cardiac output? And if you don't have an echo, you don't have a PA catheter, your opportunity to adjust inotropes is really based on looking at your SCVO2.
I think so, sometimes. But I think also you have to look at things like diastolic dysfunction. You have to look at things like your relative heart rate. So if I have grade 2 diastolic dysfunction and I am very tachycardic and I don't have adequate filling time, I'm not so sure I want to give an inotrope to that person. You know what I mean? And so it may still be a cardiac issue, you know, but it's probably, there may be some combination of preload, afterload, contractility I have to address, whatever that is. Now, does that mean I have to go through dobutamine as a person? No, not necessarily, of course. You know, but somewhere in that range, you have to fix these problems. The question is, let's say you have a person who is a little dry and a little low in hemoglobin and a little low on SAS. How do you know which of these you have to go for? The other thing is, as we'll talk about in a minute, why have we come to the conclusion intellectually that elimination of volume responsiveness defines the optimal preload? I'm not so sure I understand how we got to that conclusion. Right? If you start out as a 20-ounce big gulp cup and now you're a 64-ounce big gulp cup with some holes poked in it, is the best strategy for me to keep pouring Coke in you to keep this level of Coke normal? Or maybe not a mutually exclusive strategy might be to shrink you down to be a 32-ounce cup instead of a 64-ounce cup, right? Maybe there's a role for pressors in this as well. And there's a big body of research looking at things like, what about shrinking the space, which is kind of where we were in the 90s. And then we went through this whole idea in the 2000s that we were not giving enough volume to everybody. And maybe we're giving too much volume to people. So we'll talk about it in a little bit. I don't know the right answer, though. A lot of it depends. What I do know is there's a lot of variation in practice. This is a study looking at intensivists, emergency medicine doctors, and internal medicine hospitalists. And which pressors they use is significantly different, whether they use clinical exam, CVP, pulmonary capillary wedge pressure to look at things like preload adequacy, when to use steroids, when to use, this is early 2000s, so you can tell that Zygris was still around. Same body of literature out there. Three very different takes on it. And I'm not so sure either any of these guys is right. I'm not advocating for one versus the other. But what I am saying, I have preferences on each of these points, but what I am saying is that the majority of critical care in this country is not done by intensivists. It's done by hospitals, right? So part of your job as an intensivist is going to work with your hospitalist colleagues to try and make sure everybody's on the same page for how we're doing all this stuff, right? That would be part of your job. So use of bundles and protocols. So, poor Manny. Yeah, just poor Manny. So, early goal-directed therapy. This was the Bible for how we were going to resuscitate people for a long time. We're going to drive to an ICP of 8 to 10 if you were unintubated and 10 to 12 if you were intubated, and we're going to give fluids until you get to where you want, and then we're going to drive your MAP to be 65. People forget about the greater than 90 part. You're supposed to give a vasodilator if the MAP goes above 90. Okay? And then we're going to look at SCVO2s, and then if it's low, we're going to give you blood so you can move up to 10, and it's still low, then we're going to put you on inotrope, right? Because nobody had bedside ultrasound at the time. That was how you decide inotropes. And this is exactly probably a little bit what Jordan's getting at. That's exactly what that part of early goal-directed therapy would tell you to do. It doesn't tell you anything about why this may be low. You may or may not need inotropes, but this is how it's done. So, process, guys. This is the American study, right? The American study comes along, looks at a bunch of centers and says, listen, we're going to look at primarily academic emergency departments, and we're going to randomize septic shock people into 3 groups. You're going to get early goal-directed therapy, you're going to get this protocol-based standard therapy, and you're going to get this usual care. Right? The majority of people in an academic medical center, who's making the decisions in an academic medical center? Is the attending? Minute to minute, day to day, standing at the bedside, making decisions? No, it's not, right? Because I'm up here giving a talk, right? Anthony's downstairs running the SICU right now. What? Yeah, so I don't know actually who's making decisions on our service for the next 45 minutes. I have no idea. Hope they're good. Right? So everybody making decisions in the usual care group is younger than early goal-directed therapy. So I would look at that and I would think, huh. But it turns out you got pretty good separation among these groups, right? And actually when they looked at use of central lines, volume, blood products, all that was different. But what we found was it didn't make a difference what group you were in. You had the same outcome. Same outcome, okay? Cumulative mortality 1 year, still the same outcome. So these are bar graphs, just so you know. The reason this is important, though, is if you compare all 3 groups in the process trial versus the original early goal-directed therapy group and their standard group, okay? The fluid was much higher in both arms of the Rivers group than in this group, much higher, significantly higher. So 1.5 liters or so, maybe 2. So considerations. So This protocol-based standard therapy used a shock index that does show up in the literature. Clinically, we don't tend to use it as much. The physio guys are kind of big fans of the shock index. They'll probably show up a little bit as this starts to permeate our institution. Initially got some fluid, low Apache score compared to the Rivers group. This was not as sick a cohort as in the Rivers group, but no differences, okay? And there were some differences. Those who were resuscitated in the groups had different rates of central line utilization. Mean SCVO2 weren't measured in everybody, but there were 71 in the early goal-directed therapy group. And lactate 4 to 5 in groups on vision, which is lower than the Rivers study. I think the Rivers cohort was sicker. It's hard to compare apples and oranges, but I think they were sicker. So enter the Australians and the New Zealand guys, Kiwis and all these guys, right? So they go off and they do killer critical care research. These guys, this ANZIX group, they are all over a lot of awesome research, and they will help you immensely over the years. But they looked at 51 centers. They basically did a similar thing to the process trial, but what they did is early goal-directed therapy versus usual care, and they end up with no difference, right? And this is just, it didn't matter what criteria you had at the beginning of the study. It didn't seem to matter. There wasn't a predefined group that clearly benefited from this. These were some of the things looked at. I won't bore you too much with the details, but again, sick versus not sick was substantially different from the Rivers study. And then last but not least, the Brits came in and said, yes, but we will add a cost-effectiveness component on this. And what they showed was no difference in outcomes, and lo and behold, it was no more cost-effective to do it with a protocol-driven group, and the outcomes were no better. By the way, all these 3 studies, as they were going on in parallel, and all 3 of these guys were talking to each other. So they were designing aspects of their study to complement each other rather than to recreate the exact same study, which is, I think, kind of interesting. It's a neat study design that's getting more common. So, bundles takeaway. Traditional Rivers early goal-directed therapy doesn't seem to improve important outcomes. Normalization of SCVO2 doesn't seem to be a good marker. I still think low SCVO2 tells you something, but again, I don't think it's adequate or sufficient to just normalize SCVO2. How usual care extrapolates to non-academic facilities is not clear to me. It may be that in a non-academic center, you know, when you have an intensivist who's seeing 40 patients with, maybe with a team of nurse practitioners or PAs, and the 3 or 4 of you are seeing 40 or 45 patients during the day, which is not unusual, right? In private practice, it's not unusual. Maybe a protocol is a good idea in that setting, right? If you're in a protected space as an academic attending, and I have a fellow, and I have 2 residents, and I have a couple medical students, and I have an intern, and I'm having a crazy busy day in the unit, taking care of my 12 patients, right? I have a lot more time to think about any of those 12 patients, right? And that's part of what we bring to the table. That's part of our job. But on the other hand, that's a very different monkey from somebody out at a high-volume community center. So microcirculation takeaway, we can't control microcirculation. It'd be awesome if we could. Hi, Omer. Optimizing DO2 is probably isn't sufficient. So the rest of the talk's easy. We're going fast. Ready for this? That was the hard part. You ready? Adequate and sufficient antibiotics are good. Don't let there be holes in your coverage initially. Cover broadly based on what you think is going on. Don't miss stuff. Turns out the longer you go missing stuff, the worse the outcomes are. So the sicker you are, the more it seems to matter that you had good initial antibiotic coverage. Okay? So a retrospective review, 18,000 septic shock patients, delay in appropriate antibiotics, increased mortality. And there was a linear mortality increase with the duration of delay. So now, de-escalation of antimicrobials. That's a good thing. We want to de-escalate. Okay? People do better if you de-escalate. Don't have everybody on Septic and Pip-Taz and Cobra and everything forever and ever and ever. It turns out you grow bad bugs in your unit for one thing. The patients don't do as well. Procalcitonin. Every time I turn around, somebody wants to talk to me about procalcitonin, right? I love the idea. The problem is it has neither the sensitivity nor specificity to absolutely rule in or rule out infection. Now, a normal procalcitonin can steer you away from infection, and in certain settings like pneumonia specifically, maybe would help you in not starting antibiotics. This direction is probably the direction we're going, but the argument I would make is we're probably not ready for prime time yet. Now, there is some literature that's fairly provocative saying you can also use it to tailor de-escalation of antibiotics, so maybe. There's more on that coming, but I don't think it's quite there yet. Timing of antibiotics. This was an interesting review from the folks at the University of Mississippi, and they actually looked at the cutoffs that are used by CMS to grade your hospital. And it turns out that the cutoff of within 1 hour for septic shock and 3 hours, it turns out no real mortality benefit. It's a huge confidence interval overlap. And the point, they got lambasted when this first came out because it seemed on the surface that they were making the argument it doesn't matter if you start antibiotics early. That's not true. And they made it a point to talk about that right down here. What they said was, we do believe early antibiotics are vital, and you should have it on board, but there's nothing magical about this CMS cutoff that we're all being graded on. That's actually not based specifically in fact. That's extrapolation of some literature that was out there a little bit earlier. So, yeah, early is good. Source control. If there's pus, drain it. Okay, that's part of source control. It's not just antibiotics. Okay, that's really important. I think surgeons, my surgical colleagues, are really good at thinking about that. I think sometimes those of us in the medicine world forget about that sometimes. If you have a pleural space full of pus, you really do need to do it. You really need to drain it now. You're not going to get source control otherwise. It's important. Fluid resuscitation. Okay, if your patient's inadequately resuscitated, how much to give, how quickly to give it. I'm going to fly right through this in the lecture notes that I'm going to send out in the unabridged version. I'm going to talk a lot about this. I wanted to spend more time on the resuscitation piece of it and just the pathophysiology piece. But I will say, too much fluid is bad, too little is bad. Okay? These are actually perioperative patients looking at perioperative complications, but you can draw the same curve with mortality. So, positive fluid balance associated with increased mortality, worse than septic shock, failure of weaning. I'm not going to bore you with my thoughts on endothelial glycocalyx, but that's really important here. Positive fluid balance is an independent prognostic pattern. So, those who get more volume seem to do worse. Now, you can argue that those who got more volume were the ones doing worse, and that's why they got more volume. But it seems if you control for all other things that we can control for, study after study seems to identify the same trends. I won't bore you with that. So, I put these two things in your slides. On the wimpy version, I don't talk a lot about this, okay? But in heart failure world, you talk about things like you can't have left heart failure without right heart success, right? So what is driving your circulation is not so much the left ventricle. This is a game of getting fluid back to the right side of your heart, which is a function of the pressure gradient going from the venous side to the right atrium. The reason you die when your heart stops is because your right atrial pressure suddenly rises to match the upstream venous pressure that's always existed. This upstream venous pressure has nothing to do with your heart squeeze. Nothing. Okay? So you die because when blood stops in your heart, your right atrial pressure rises and therefore the blood stops. As long as your right atrial pressure is lower than the average pressure in the venous side, which is where 2/3 of your blood is at any given time, blood will flow. The two things that affect that, okay? Absolute volume and how much you're squeezing down, right? If I take a balloon and I put a pressure catheter in the balloon, there's two ways to make that pressure go up. I can put more air in the balloon, or I can take the same size balloon and squeeze it, right? If I squeeze it, pressure goes up. That's what you're doing with pressors, right? So the fact that you're squeezing down the arteries is not helpful. That's not a good aspect of pressors, right? That's actually a negative aspect of pressors. The value of pressors is its ability to squeeze the venous side and maintain the upstream pressure that's feeding fluid to the right side of your heart. Okay? That's a very important concept for you to understand. And these two articles really, really do a nice job. So the slides that I send you out, the unabridged version of this actually goes through a whole bunch of slides that actually walk through this from there on. But very important, the implication of that is there is nothing about the CVP that identifies whether somebody should or shouldn't get volume in the setting of septic shock. Nothing. They've done over 100 prospective studies looking at CVP as a marker of volume responsiveness in humans. None of them have shown CVP correlated with that. The one positive one that's out there was done in horses. And Paul Merrick writes a great review article on that, something about the tail of the 7 mares or something like that. So central venous pressure, what we will say is your CVP, 0, 5, 6, 10, 11, 15, doesn't absolutely predict responders versus non-responders. Seems to trend that way, but it doesn't absolutely predict it. So if I look at volume responders versus non-responders, i.e. I give you volume and your cardiac output goes up, CVP doesn't necessarily identify it. It did in 2 studies, this one, in an experimental setting, but the other ones it did not. And that's RV. But the tracing of the CVP may be very helpful. If you have a lot of respiratory variation in your CVP, that may argue for volume responsiveness. These are all people who got volume, and this is what happened to their cardiac output. These are responders on the left, non-responders on the right. Non-responders tend to have the CVP tracing look like this. So sometimes I'll actually have somebody transduce a CVP for me as part of a tiebreaker. If I see a lot of variation, that tells me one thing. If I see no variation, that tells me something completely different. There's nothing about the CVP number that I was making a decision on. Okay? It's the waveform may be helpful. So pulse contour analysis, I spent some time in the big slides talking about this. Just to understand that pulse contour analysis doesn't do well in states where you have variable SVR. It is least well validated clinically in septic shock patients because it is making assumptions about what your SVR is in order to take your demographic data and convert what it's seeing on an arterial waveform and converting that to an estimated stroke volume. So it's making an assumption about what your SVR is. It's not measuring your SVR at all. So if you have a variable SVR or a low or an abnormal SVR, it doesn't work well in that setting. Okay. So what I'm really trying to capture, though, is this idea of a pulse pressure variation. So if my preload increases here, if I give more fluid across the x-axis, do I get an improvement in stroke volume, or do I not get an improvement in stroke volume? Volume non-responsive, volume responsive. I want to identify that group. But understand the preload change with respiration is actually identical, whether you're plump or not. And that's because that's a function of your IVC collapsing at the level of the diaphragm with the pressure change across the diaphragm with your chest and your abdomen. Even if you're plump, that is going to pinch down. Okay, it's going to pinch down right there. So, preload reserve or not, give volume or not, that's what I'm trying to identify. Stroke volume variation and pulse pressure variation are generally the same thing. The difference between your SVP and your diastolic blood pressure general reflects your stroke volume. So if I have stroke volume variation, I ought to have pulse pressure variation. So you can whip out the Vigileo, you can whip out Nikon, whatever you want to do, but at the end of the day, I can give as much information from the arterial wave tracing. Lots of caveats to that. So that's just graphically saying it. This is in the back of an airplane. This is pulse pressure variation. Right? This person was super dry, leaving it down. Now, someone has pointed out to me, you've seen these slides before, yeah, but your CVP is low too. Yeah, but notice how much variation there is in CVP. If I measured it right here, it's 10. And notice how it goes in time with respiration. This is an in-tidal CO2 monitor. Exhalation, CO2 coming out. Inhalation, CO2 going away. So blood pressure goes up after a period of exhalation because they're phase shifting. Okay, so if your pulse pressure variation or stroke volume variation is greater than 13%, it argues you're volume responsive. If it's less than 13%, it's a coin flip. Don't feel good about it, SUV of 8. What you want to do is feel bad about an SUV of 18. I don't want you to feel bad for yourself, but you know, it means you need some volume. Unfortunately, it's validated in people with normal rhythm, actually technically in a perioperative setting. This is all done for FDA approval of devices. 8 to 10 cc's per kg. You have to be completely passive, so paralyzed, right? Normal chest wall, normal abdominal wall, normal compliance to the lungs, all these things. And yeah, so that's no patient ever in critical care. Never happened. But area under the curve, pulse pressure variation, 0.94. That's really good, right? Perfect test would be 1.0, right? Stroke volume variation, 0.84. Excellent. How about your CVP? 0.55. 0.5 is a coin flip. Coin flip. Barely better than a coin flip. Don't waste time checking your CVP. Not worth it. Doesn't help you. Nikon, I talked about this a little bit in the slides, but basically something called bioreactance, and it has to do with resistance and capacitance going across two electrical impulses go across the chest, one here and one here, and you basically triangulate. And it looks at a waveform and it creates, so maybe in diastole, one looks like this, the other looks like this, and then systole, this one flips and that one flips another way. And the machine takes that, plugs it into an algorithm, and says, the only thing that electricity travels through in your chest is fluid, right? It doesn't travel through the air, it doesn't travel through bone. So if those things are moving, that has to reflect a volume of fluid that moved in your chest. And the only thing that's moving is your cardiac fluid, right? So it makes some assumptions about your stroke volume. And I talked very briefly about Nikon, okay? I want to make sure everybody understands there's a big section on this in the slides because I don't want Jordan to feel bad about this. Jordan brought this technology to our institution, and I love it, and it's wonderful. So it's my very favorite. So you can just give volume, right? You can do passive leg raise. You can mobilize volume here. This is probably the best validated way of assessing volume responsiveness right here. Everything else is estimating. Raise the legs, hold them for 30 seconds, for 3 minutes. Have some technology on board that you're following the cardiac output with. Whether you use Vigileo, whether you use Nikon, probably doesn't matter, whether you use your PA cap, whatever, and see what happens. The way it was originally described is lying on your back flat and then raising your legs, but if you want to increase the sensitivity to it, have them seated up at about 45 degrees and then rock the entire bed back, including the legs out. Okay? And our beds will do that, kind of go like that. That actually mobilizes fluid that's also in your pelvis, so it increases the sensitivity but will decrease your specificity a little bit. Passive leg raise showing changes in, so IVC variation, you can do this at bedside. We're on the home stretch. You can do this at bedside. I actually am a fan of this, but I don't think it's a perfect tool. Okay, there are a lot of patients who may not have any variation here who may be dry or relatively dry, right? If you have wide open TR, this may actually not have a lot of variation. So that you can be fooled on a little bit, I think. Aortic blood velocity is actually really good. I can't measure that. I'm not good enough with echo to do this. Just not. But if you look at the area under the curve, luckily stroke volume variation does better than either. Variation in cardiac, in IVC variability does next best. Where you make the cut points of this depend a little bit, will dictate your sensitivity and specificity. If you're looking for a little change or big change. If you're looking for an absolute change or percentage change. And a lot of discussion about that. And so, to me, I just think passive leg raise probably makes a little bit more sense, personally. But, again, I don't do it a lot. You know, I've tried it a few times. Sometimes I think it works, sometimes I don't. What are you going to give? You want to give isotonic crystalloids. I have a whole section in the slides talking about expanding your extracellular space. But what I will say is this. Safe trial, saline versus albumin. No benefit to giving albumin. However, people who got albumin reach their endpoints faster, and just for my neurocritical care colleagues in the back, don't give it with bad brains. Okay? It seems to do really poorly with bad brains. Don't give albumin for bad brains. But albumin, achieve resuscitation goals faster. Crystal trial, no big difference between the two. Alveos trial, very, very important. If you're a big fan of albumin, you love albumin, you shut down critical care pharmacy medicine, man. They did is they looked at people with shock, sepsis, and they said, no benefit to adding albumin to crystalloid. No benefit. Except, well, we went back and looked at the people with severe septic shock. There was actually a mortality benefit to giving albumin. Make of it what you will. I'm not advocating for or against it. I'm just saying, if you're an albumin fan, you pull that out. Okay, you got a card. Boom. You're welcome. I'm going to write a whole critical care textbook justifying all the things we should be doing. But in general, albumin, not so much. Starch. Anything that says starch, don't give it. Hydroxyethyl starch, pentastarch, whatever. Pentasepta, hepta, nanostarch, I don't care. If it's a starch, don't give it. Bad for kidneys, probably bad for outcomes. Yeah, and specifically said in Canada, we really don't want to do this. Takeaway, got to get it right, okay? Isotonic crystalloid. If you have an C-suits colloid, like you're bleeding to death, use blood. Vasopressin utilization, norepi is probably better. VAST trial, when, sepsis spam, this basically said, hey, listen, people with hypertension, if you run to a higher MAP goal, you might have slightly decreased kidney injury, but otherwise no big benefit to doing that. So in general, you don't really have to run the higher MAPs. This is different. It depends. It totally depends. So I tend to, certainly if I have ICP issues, that's a different issue. If I have somebody with marginal kidney stuff, I usually will drive it to 75 or 80. And it's a gross extrapolation of that study, a gross extrapolation, because that's not actually how they were doing it, but I tend to. Is that right or wrong? I don't know. I tend to be more inclined to do it in people with a history of bad CKD. Yeah, so traditional MAP goals are probably okay, and what you're going to use probably matters a little bit. Just remember that, yeah. So norepinephrine and dobutamine versus epinephrine, no benefit, one or the other. I tend to start with norepinephrine. If they're failing that, I may try epinephrine. If somebody has a relative bradycardia who's hypotensive, I may start with epinephrine as my first choice. Because if they have some degree of chronotropic incompetence and I want to drive the heart rate up a little bit, I may start with it. Better than dopamine, right? By the way, those of us who are dopamine haters, you know, if you really look at how dopamine's doing its business, it's not that far off of, you know, norepinephrine is not that far off. But I tend not to use dopamine for septic shock. You can usually tell when somebody trains by whether they like norepinephrine or whether they like dopamine. And I'm just inside the youngest cup where we like norepinephrine. About 5 years older, and I would have been a dopamine fan probably. And so vasopressin. Okay, so the VAST trial, you have to know the VAST trial. No benefit to mortality to adding vasopressin to norepinephrine in all comers with septic shock. However, those with wimpy septic shock who started with a norepi level of 5 to 15, and that was a predefined a priori group, those folks actually had mortality benefits, sort of, to adding vasopressin. Depends on how you want to cut the p-values. But pretty good, not bad. Weird that you get like a 90-day mortality because of that. Just makes you wonder. It's one study, but we've completely built our practice on it. So my takeaway with vasopressin, if you're adequately volume resuscitated and you're on greater than 5 mics of norepi, just add vasopressin, because if you're in 5 to 15, there's a mortality benefit. If you're 15 or greater, well, you're already failing and you're going to have vasopressin next anyway. So if I'm greater than 5 and I have enough volume on board, I have vasopressin. I think that's most of it. Blood products give it for hemoglobin greater than 7. Really not a lot of data to suggest pushing this higher. If you're actively ischemic, that's a group. Some people have tried to push it higher, 8.5 to 10, but really not a lot of literature to support that. And just remember that every unit of blood product you give is altering somebody's inflammatory response. Inotropic therapy, if you have a low EF, go ahead and give it. Not a lot of great data to support giving it in most patients, but biventricular systolic dysfunction is super common, and some people may actually benefit from it. Corticosteroids, no. No, overall. Now, if you are failing pressors, relative adrenal insufficiency is actually very common. Unfortunately, doing a court stem test doesn't help you figure out who is going to benefit from this and who's not. Corticus trial, no survival benefit to using steroids for septic shock. However, those who survived got off pressors faster. Hate those things. And then last but not least, Drotrocogan alpha, Zygris, gone. They took it away. That's a couple slides earlier. Glucose control seems to be a good idea. Keep it below 200. Zygris activated protein C does all these good things. Unfortunately, first study says do it. And then by 2005, we had studies saying, okay, do it for the super sick people. You know, Apache 2 greater than 25. And then by 2012, we were like, yeah, we're pulling this from the market. So it's gone. But sometimes you'll hear people talk about it. And then I think that is most of it. All of this stuff, renal replacement therapy, extracorporeal circulation support, ethylene blue, you know I got a section on that. And plasma arginine, I did not add anything about angiotensin 2, which I could have, and could have said no, but clever idea. But maybe in the future. But right now, these are all in the big talk. Okay, so I'll have folks send this out to you. Where do we go from here? I think we need to figure out what adequate sepsis resuscitation looks like and figure out which points are most important to resuscitate. I think you can teach a computer to recognize certain patterns and understand that this means dry, this means, you know, vasodilated, this means cardiogenic shock, whatever. And you can actually have a computer algorithm put all these together and say, oh, if I really want to be here, I have to move volume this way, pressure this way, stroke this way, or whatever to get over to there. And I actually think that's where resuscitation is going. This actually came out of an emergency medicine journal, and it was a fascinating article. I actually think that the things that we have to be responsible for septic shock resuscitation are beyond our brains right now. And I think we're not very good at it right now. I think the challenge with this is figuring out what's hard enough data endpoint to justify each of the points that you would put in here. And I think that's the challenge. But I think that's where we're going in the next 5 years. Probably, well, I'm an optimist, next 20, 25. But we're going to get there. If you go to LDS Hospital in Salt Lake City today, most of their ICU is driven by protocols. And when you're a fellow rotating there, because I did that, when I showed up, they gave you a binder. And they said, okay, every protocol this patient is eligible for, they're just going to be on. And you're going to just watch this. And you're going to have to figure out when to pull them out of a protocol because they're failing it. And it was an act of God to pull them out of these protocols. DKA resuscitation was a wall of drifts and things behind them, and a computer was running. And they did great. So who knows? Is that the perfect way to do things? I don't know. That assumes that you have the right algorithm, the right protocol. And that's what we're probably still searching for. But anyway, that's it. It's hard. You need to become the expert, and the slides that I send you hopefully will help you to do that. And I'm sorry that took me so long, but that's not bad, right? 6 minutes over, 7 minutes over, 7 minutes over for 188 slides, man. Boom. So I'll send out the unabridged version to you guys, though, because I take some time to go through it in small chunks, but I do think it's a reasonable survey of the literature as it is out there in general that you're going to need to be responsible for understanding all of these concepts. And as usual, I'm available anytime, happy to talk at any time.
Do you have a card down to 6, or do you have 3 minutes for a question from Matt?
Yeah, sure. Yeah, of course. For ARDS stuff?
Yeah.
Yeah, absolutely.
3 minutes, and not 40.
Yeah. So I'm just getting into this stuff.
Yeah.
And I started with the Amato 2015 paper. So
Yeah.
I've got my driving pressure and plateau minus P. And in the paper, it's neither of these that are predicting good. And it's so the driving pressure is capacity over compliance, and it's not load this that's driving the positive outcome.
Right.
Why is it not just compliance? Why in that paper is it not just people who had compliant lungs did well and people with poor compliant lungs did poorly?
Because it was never the compliance that was the issue.
And I know so, is a low volume.
So in any given moment, when you have, are there people waiting out here?
No, I'm going to
Okay.
sit down, but Jamie wants to know if you are going to interview a candidate tonight.
Sure.
Like right when you're done with this.
Yeah. Yeah. I thought they'd canceled that. No, I got an email from Jamie this morning saying that I'm not interviewing today.
Oh, well, she just now she asked me.
Oh, sure. Yeah.
Change your mind.
Yeah. Just give me a few minutes. I'm happy to. Yeah. Yeah. So here's the thing. So we've always taught it as low tidal volume is the thing, right? So at any given time, as you point out, right, and this actually comes from the equation of motion, where your pressure at the mouth is a function of change in volume over compliance plus